budget proposals of the Republican Party, it is necessary, if you will, to be able to come together and to listen in one voice, finally, that we act to help America. With that, Madam Speaker, I yield back my time.
The gentlelady from Texas yields back her time. For what purpose? Under the Speaker's announced policy of January 5, 2011, the gentleman from Texas, Mr. Burgess, is recognized for 60 minutes as the designee of the Majority Leader.
And I thank the gentlelady for yielding. This afternoon, the Congressional Health Caucus wants to talk a little bit about the future of the government's role in health care in this country, and I recognize for those of you studying your Constitution at this very moment, you don't find the government's role for controlling health care in this country, but we will do our best to help you understand why we are where we are and perhaps where we are going with some of the federal programs that are run by the federal government. Again, the Congressional Health Caucus, the website healthcaucus.org. This hour is great. I'm grateful to the leadership of the Republican Party for the use of this hour. Myself and my co-chair, Mr. G.T. Thompson from Pennsylvania, will be leading the discussion. We've had a lot of talk over the past 4 weeks about the future of Medicare in this country. Certainly, if you look at the 3 plans that are on the table right now, and I understand you may be scratching your head saying, wait a minute, I thought there was only one plan out there. I thought there was only the Republican plan. But the Medicare trustees report that was issued some 2.5 weeks ago, which came forward and articulated how the Medicare Trust Fund would be exhausted in the year 2023 or 2024. This is a significant fact that right now this Congress and the White House is trying to ignore, but it can't be ignored, and that's why the responsible Republican budget passed in April would deal with this fact. But one plan would be to continue on the current course and make no change at all, and that is what the trustees report articulated. The trust fund is exhausted by 2023 or 2024. That means then all funds to pay for Part A, Part B, and Part D of Medicare, hospitalizations, physician payments, and pharmaceutical payments would all come from the federal treasury. The trust fund would be depleted at that point. What are the implications for that? The implications are, as we sit here even now and talk about things like expansion of the debt limit, the implications are that all of the funding for Medicare, for the hospitalizations, for the physician's part, for the pharmaceutical part, all of the funding would come strictly out of the general revenues, out of the that part that is paid by the taxpayers every year. Are there things that could be done under the trustees' report to prevent this from happening? There are, and one of those things would be to raise the tax on the payroll tax that is paid by individuals for their Medicare. All of us pay a 1.2% tax. The employer matches with a similar amount, so that comes out of our paychecks every 2 weeks or every month, however we're paid. There would be a way to increase that tax to perhaps sustain Medicare farther into the future. But I must remind the Speaker that this law, which was signed by the President in March of 2010, the Patient Protection Affordable Care Act, already had a Medicare tax increase included therein. So there's a 0.9% Medicare payroll tax that is included in the Patient Protection and Affordable Care Act, which leaves us very little room to maneuver unless the payroll tax goes up even further. Many people argue that the payroll taxes are some of the least progressive and most regressive taxes in this country because they are administered across the board without regard to income. So this is a potential problem. It's one that perhaps could have been solved with a payroll tax increase, but that payroll tax increase has already occurred. You say, well, but okay, if there's a payroll tax increase in the Medicare Trust Fund, then that's good news, because that means Medicare goes on farther. Unfortunately, under this law, the money is taxed on the payroll, collected by the Medicare Trust Fund, makes a very short stop in the Medicare Trust Fund, and then goes to fund a very different program, a program that in fact does not exist today but will start in 2014, a program of subsidies for entitlements for people to purchase private health insurance in the non-Medicare years in what are called the state exchanges. So the money goes from the Medicare Trust Fund to fund a new entitlement. That money will have to be paid back to the Medicare Trust Fund, make no mistake about it. It's money we're borrowing from ourselves, but it is not money that is there to save Medicare today. And when the administration argues that, hey, within the Affordable Care Act, we've already done some things to sustain Medicare into the future, nothing could be further from the truth. In fact, they probably poured gasoline on the fire that was already in existence. One of the other things the trustees' report suggested was that benefits could be cut in the future. And I dare say that if nothing else happens and we get to the point where the trust fund is exhausted, those benefit cuts will be enacted, not by this Congress, not by the next Congress, but some Congress in the future, because the intergenerational strife that will occur because of the inability to keep pace with the problems that were made by generations before with generations yet to come, the unfunded liabilities in the Medicare Trust Fund will soon begin to outstrip every other activity of the federal government. That is, no money left for defense, no money left for transportation, no money left for education. All of it will go into health care in some way, shape, or form. Well, did the President have a plan for sustaining Medicare? Well, yeah, you heard about the tax that he already enacted in the Patient Protection Affordable Care Act, but that may not have been so helpful. In fact, that may have been more detrimental. What other things has the President put out there on the table as a plan for saving Medicare? Now, bear in mind, there is no presidential plan to save Medicare. We have encouraged the White House to provide us with such a framework. We would like to see such a framework. They could send it over to the Congressional Budget Office and have it scored, have it compared to Republican proposals that are out there, but this ask has not yet been honored. So as a consequence, what we are left with are the bits and pieces that the White House has articulated, the administration has articulated, that here is our plan for Medicare. And one of the big plans they have for Medicare is contained within the pages of the compilation of the Patient Protection and Affordable Care Act on page 423, where it talks about a new board that is created that is going to administer Medicare costs. This is the Independent Payment Advisory Board. Who will these individuals be? Well, they'll be 15 in number. They will be nominated by the President. They will be confirmed by the Senate. They're to be made up of academics, of people who've worked in government, people who have expertise in health finance and economics and actuarial science, health facility management, health plans and integrated delivery systems, and way, way down at the bottom of the page, yeah, you might get a doctor or nurse on that board as well. 15 people that are paid by the government to do nothing but identify cuts in the Medicare system. Well, perhaps that's a good thing. Perhaps that's something that's necessary. Now, look, I'm a member of the United States Congress. The Speaker is a member of the United States Congress. We are the people's house. It is our job to deal with the people's money, to tax the people, to raise the money, to spend the money, and be good stewards of the people's money. It is not our job to hand off that obligation to the executive branch, or worse yet, to a board that is appointed by the executive branch and is accountable to no one. It is not our job to do that. It is our job to have the oversight over the federal agencies and boards so that we can ensure that things are done properly with the people's money. In this case, the Independent Payment Advisory Board will be just that. It will be absolutely independent of the legislative branch. Once the action is taken by the Independent Payment Advisory Board, it becomes very, very difficult for Congress to impact the decisions that are thereby made. Now, true enough, their job is to deliver back to the House and the Senate their recommendations for cuts in the Medicare system, and it's very detailed in here on those pages as to just how much they are required to cut. It's very detailed as to the procedure for bringing those cuts to the House and the Senate and which committees they go to for evaluation. But here's the deal. At the end of the day, Congress either votes up or down on this menu of cuts that's provided by the Independent Payment Advisory Board. Yes, we can vote no. Yes, we can turn down the recommendation of the Independent Payment Advisory Board. What happens then? According to statute, we're not finished. Congress then is required to produce the same level of cuts that was recommended by the board, maybe taking it from different places, but still the same amount of money has to come out of the same federal program, that is the Medicare program. Well, what if Congress gets together and says, we don't like what the board has delivered to us, we're going to produce a different menu of cuts, but then, wouldn't you know it, Congress can't agree on what those cuts should be. I know, Madam Speaker, you'll find that hard to believe that Congress could ever get to a point where it didn't agree with itself on very much, but it could happen at some point in the future that things would be so contentious in Washington and so contentious in the House and the Senate that we couldn't agree with each other on what those cuts would be. Well, what happens then? What happens then is the cuts recommended by the Independent Payment Advisory Board are in fact delivered to the Secretary of Health and Human Services, whoever he or she may be. The following April will enact those cuts. There is no getting away once those cuts are recommended, and again they are dictated in statute. Once they're recommended, they are going to be enacted. There is almost no way around that. We've got kind of a similar situation today with a different formula that deals with only Part B. That's only the part that reimburses physicians. It's called the Sustainable Growth Rate Formula. It is a very complex set of figures and numbers that deals with some federal targets. It deals with conversion factors. It deals with update adjustment factors. But suffice it to say that it requires a reduction in reimbursement for patients' visits to doctors, and it does this every year. Now, Congress historically has come in at the last minute and rolled those cuts back and said it was that we won't enact those cuts. The problem is with the formula as written, every year that we come in and say, okay, doctors and patients, we're not going to actually cut reimbursement rates this year, every time we do that, that aggregate number that should have been cut, it is added to the sum that ultimately must be cut. So right now we are existing on a gift, if you will, done in the lame duck session of the last Congress, where the cuts in Medicare were given a 13-month reprieve, but if Congress doesn't act by December of this year or January of 2012, a almost 30% cut goes to physicians who practice in the Part B part of Medicare. Now, I know you can say, well, doctors probably make too much money anyway, and the government needs to save money, so what could that hurt? Where that hurts is that doctors are having a tough enough time keeping up with their expenses. When we cut them 30%, the nurse that works in the front office or the company that delivers the electricity to keep the lights on in their practice doesn't say, gee, doc, we know you're having a tough time and the government cut your reimbursement, so we're going to give you a break on your electricity bill. That does not happen. The good people in the municipality that allow the doctor to practice don't come up and say, doctor, we know this is tough on you. We're going to give you a 30% reduction in your school taxes for this year on your business property. That does not happen. Those fixed overhead expenses occur, and the federal reimbursement rate for Medicare and the Part B program reduces year over year. That is why you have doctors leaving the Medicare program, and as a consequence, that is why you have people who are entering the Medicare program, turning 65 or older, who move to a new location, call up a doctor's office and say, I need to be seen for my whatever, and the answer is we are not taking new Medicare patients. That unfortunate reality is hitting people today. The Independent Payment Advisory Board is theoretical. That's in the future. The SGR is the here and now that Congress is dealing with even this year. Now, I'm very fortunate to have been joined by my counterpart on the Congressional Health Care Caucus again. Healthcaucus.org is the website. G.T. Thompson from Pennsylvania, thank you for being with us this afternoon. Let me yield to you such time as you may consume.
Well, I thank my good friend Dr. Burgess from Texas for yielding and also for being able to work with him in terms of our Congressional Health Care Caucus. We cover the health care industry from both important aspects. You as a physician and all of your experience in the medical, specifically the medical field. My background came up through therapy, and most of my almost 30 years of working in nonprofit community health care was really on the administration side. Some as a therapist, but largely in administering programs in hospitals, in comprehensive rehab centers, nursing homes, as licensed as a nursing home administrator towards the end of my career there, and frankly dealt very, very closely with Medicare out of necessity, because Medicare is, on the inpatient side, is at least 60% in terms of market share, in terms of payment. And so Medicare is very important. I have to say to my good friend, I was pretty naive when I came to Washington in January 2009. That's when I was sworn in. I won the election in 2008. I thought everybody knew that the impending crisis one of those had to do with the insolvency, the eventual bankruptcy of the Medicare program, only to get here and find out that that was not on the agenda under the previous leadership, and frankly it has emerged because it is a truth. When you look at the situation today with the Medicare system, Medicare is in jeopardy. And what we're trying to do, what the Republicans are trying to do, is to save Medicare. The thing that would hurt Medicare the most is to do nothing, to further kick that can down the road. Just by coincidence, I stopped by earlier, that I was off the hill, stopped by and I picked up a prescription earlier today. You know, the only prescription to save Medicare is a Republican prescription. I have to tell you, on the Democratic side, they're just willing to pull the plug and let it die, because if you don't make changes to the Medicare program, that's exactly what happens. And that's not political rhetoric. That's coming from some pretty credible sources that you talked about. Last Friday, the Medicare Trustees report confirms that the Medicare program is already contributing to the federal deficit and will continue to do so for the next decade. That since 2008, the program has run a cash flow deficit, a fact that's been largely ignored in Washington, and still there are those of our colleagues who choose to pretend it's not true, but it is the truth. And in fact, 2011, that exceeds $32 billion. That's a program that is, if we don't make necessary reforms to save it, it will go bankrupt. And what an injustice that will be for all of us, all the people across this nation who have paid into that program, who are looking forward to hitting those retirement years to be able to access and utilize that benefit. If we allow it to go insolvent, if we don't reform it, we don't save it, it goes bankrupt. The only thing keeping the program afloat financially really is the sale of Treasury bonds in the Medicare Trust Fund. And when those bonds are cashed, that increases the deficit. So what we're seeing, the president, I don't know if his plan, I guess, is to let it to go insolvent, because I read today he's restated he doesn't want to do anything about Medicare, leave Medicare alone, which essentially says let's leave it go bankrupt, let's let it go away. And in fact, the measures, and you did a great job of, I think, talking about one in particular, the Independent Advisory Board, which essentially takes the decision-making out of the hands of those of us who are accountable, those of us who are elected every 2 years to make decisions about Medicare. And those decisions will not be about what benefits to expand in this financial situation. This will be about where to make cuts, where to ration care. And, the federal government already does that. Under Part B, if you are in a nursing home and you need to receive rehabilitation therapy, the federal government has already put a cap on how much therapy that you're able to receive. And it has nothing to do with what your need is. It has to do with how much dollars have been spent. So if Americans think that the federal government would not do rationing, it already happens. It already happens. You talked about the board. We've got what the president has done. I think his plan, which really I think is going to pull the plug on Medicare, a program that's already financially insolvent and challenged. He cut $575 billion from the Medicare program to fund his health care initiative. He cuts over $200 billion from Medicare Advantage and forces over 7 million seniors out of their current Medicare plan. The projection from from the CMS actuary. This is the person who is responsible for really crunching the numbers for the Medicare agency, Richard Foster, in April 22nd, 2010. He said 15% of hospitals, nursing homes, and home health will close because Medicare pays less under Obamacare. We have an opportunity here to do the right things and to reform Medicare and to save Medicare. You know, the President has an obligation to do that. Under the Medicare Trust Fund, there actually is what a lot of folks don't know. There is a requirement, a statutory requirement, that at whatever point the Medicare Trust Fund is using more than, reaches a 45% level for more than 2 years, the President is required to put forth a plan essentially to save Medicare, to be able to address Medicare. We are way past that trigger, and President Obama knows that. I assume he knows that. It's a part of his job, and he has he has chosen to ignore his responsibilities to really put a plan forward. And in fact, when we were at the White House just earlier this week, the President said that he was not going to put a plan forward for dealing with Medicare. He was going to just not take the leadership on that issue. We have, and I'm very pleased with the plan that we have put forward. It has to do with putting premium supports. Our plan would direct Medicare to go out and to bid out for many different vendors, health care plans that seniors could then shop through. Medicare sets the standards. These companies that would put these products forward have to meet Medicare requirements. It's not a new concept. It's what we do under Medicare Part D today. And Medicare Part D is probably one of the few government programs that have actually come in under budget. Most government programs come in way over budget. I think we know that. But Medicare Part D has come in under budget, and it also is going to put, I think, an emphasis on prevention and wellness. And that's the most cost-effective type of health care that's out there. We're keeping people well. That's what we need to do, obviously. That's the best thing for the individual, for folks to remain healthy as possible. We're not talking about voucher programs. We're not talking about privatizing Medicare. Those are concepts that that's just not true when people claim that we are. We're talking about providing people choice of quality products that meet a minimum standards that the Medicare agency will assure that's there, because they're the ones that are going to bid this out and manage the process. And then we're going to provide premium supports to allow our seniors, and we're talking about just impacting people that are younger than 55 years of age. If you're 55 years and older, there won't be any change, although I've bumped into a few that want to know why they can't have this opportunity, because they think it sounds like a really good thing. But the fact is, what we're doing is holding those harmless, age 55 and older. And so I think it's very important that we have this debate, but it's a debate that brings forward all the facts and the realities of what we're talking about. And what we're talking about is doing something that will actually, I think, improve Medicare, just like Medicare Part C, which is Medicare Advantage, has been shown that seniors on that has allowed individuals to be, because of the emphasis on prevention and wellness, they've been hospitalized fewer days and for smaller length of stays, which has saved money in the long run, and it's kept people healthier. So we're talking really a positive investment in the health care of our seniors, to be able and saving the country money, and frankly saving Medicare. And so I appreciate the opportunity to join my good friend from Texas, and this is a conversation I think that's going to be very important. We continue this conversation all throughout the rest of the spring and well into the summer.
Well, well said, because that is exactly the point of this exercise this afternoon. These are difficult concepts, and they are very easy to demagogue. They're very easy to demagogue against the Republican plan. The President himself may choose to do this. Certainly the Democratic leadership in this House has chosen to do this. They do that in the absence of putting forward their own plan, but let's be realistic. We talk about things like premium support. Now, in the 1990s, I'm just a regular guy practicing OB-GYN in Louisville, Texas. President Clinton recognizes that Medicare is going to be headed for difficulty in a few years, and he convenes a big commission, the bipartisan Medicare commission that's going to save Medicare. Senator Frist, who at the time was relatively new in the Senate. He was a heart surgeon from Tennessee, was thought to be, at that time, he was recognized as one of the thought leaders in forward thinking in health care reform. So Senator Frist was on that commission. Senator Breaux from Louisiana, a well-respected conservative Democrat, was on the commission. Bill Thomas, who subsequently became chairman of the Ways and Means here in the House, was on that commission. The Breaux-Frist Commission, and people can Google that and look that up on the internet, but the Breaux-Frist Commission came up with a series of recommendations to the Clinton administration on how to sustain Medicare into the future. The Breaux-Frist Commission had a number of recommendations, but the centerpiece of what they recommended to President Clinton was this concept of premium support. It was not necessarily new with them. It had previously been described by the Brookings Institute, certainly not a conservative think tank, probably regarded more as a moderate to somewhat left-of-center think tank, but the Brookings Institute had come up with the concept of premium support. People like to try to describe what the Republican budget produced as a voucher system. That is, in fact, incorrect. And I will tell you, I was a little bit surprised that members of the administration, when the Republican conference was called down to the White House earlier this week and had a discussion with the administration, I was a little surprised that they required some instruction as to what premium support actually was and what the history of premium support actually represented, that it was, in fact, developed by a moderate think tank, that it was embraced by a centrist to center-left Democratic administration in the Clinton administration. And the Clinton administration essentially took this idea, evaluated it, and put it on the shelf and said, we're not going to consider it because there were too many special interest groups on the left who did not like the concept of Medicare moving away from central federal control. But what premium support represents is, in this case, a purchaser, in this case the United States government, going out and negotiating with insurers, saying we have a bank of patients who are going to require care, i.e. our seniors on Medicare, and this is the type of claims history that they've had for the last several years, and we would like to see if you would be interested in developing a proposal for what you can do for our patients. So it's essentially a request for proposals that goes out from the federal government, yes, to private insurance companies, some for-profit, some not for-profit. The only requirement is that they be able to show that they can take care of the patients that the government where the government needs help with its seniors, and produce a product that is going to be cost-effective and is going to deliver quality care to the patients. A voucher system, and again, I was somewhat startled that members of the administration required instruction in this regard. A voucher system would be essentially giving a check to someone and saying, go out and negotiate and cut your best deal with an insurance company. A premium support system is the government going out, negotiating with the insurance companies and saying, come to us with your best proposals for taking care of your Medicare patients. Now, some people will say, well, that's preposterous. That would never work. GT, you were not here when Medicare Part D passed. I was. Part D was built on that premise. It was, let's see if there is an interest out there in providing a prescription drug benefit for seniors. Since we were criticized that no one in their right mind would provide such insurance for seniors, we had a fallback position. It was a Medicare prescription drug program exclusively, not one run through a private intermediary. There would be parts of the country that no insurance company would show up to bid on or to make a proposal. And what we got was indeed a surprise. After being criticized for several months that no one is going to show up to participate, we were criticized then on the other side because people said there are too many plans out there from which seniors have to choose. A senior goes to Medicare.gov for a prescription drug plan, and in the state of Texas there were 45 plans available at subscribing at different rates. You could pick the one that most consistently met your needs for a prescription drug program, but it really was indeed a pleasant surprise. And because of the competition between so many plans, the prices were vastly under what had been projected by both the Congressional Budget Office and the Office of Management of the Budget. and one of those few programs that came in on time and under budget where the satisfaction rate is in excess of 94%. And very few seniors today would be willing to give up their Part D coverage under a Medicare prescription drug program. Yes, it has had some bumps and bruises along the way, but a lot has been learned in the process, and now the concept of premium support is much more developed in 2011 than it was in 2003 when the Medicare Modernization Act passed. So the premium support, and again, I was surprised that members of the administration required sort of remedial learning on this, but at the end of the morning, I hope they understood better that it is not necessary to demagogue against the Republican plan, because after all, it is a reasonable plan that has been tested with Medicare Part D, satisfaction rates high, cost of delivering the care under what was projected, and why in the world wouldn't we draw on that worthwhile experience? Now, what do you do about someone who is between the ages of 55 and the end of their life? What do you do with someone who is reached that point where they have basically made all of their assumptions and plans based around what the government promised they were going to do? For that individual age 55 or older, nothing changes. I happen to fall into that age group. I would actually, as Mr. Thompson alluded to, I would happily opt into the group that is going to have choices, because I would rather have choices than a proscribed benefit. But nevertheless, those individuals who are 55 and older will see no change, the thought being that they have already structured their lives and their retirement based on the fact that this promise had been made. For individuals who are younger than that, where there is still time to make some adjustments in your post-work years, your retirement years, there will be a different program. Now, you say, well, is that fair for people who are 54 years of age and younger? Is that fair to do this? Well, I think both Mr. Thompson and I have articulated what fair will look like if you don't do something. What fair will look like if you don't do something is either vastly restricted benefits, as has been recommended by the Medicare trustees, vastly restricted benefits as dictated by the Independent Payment Advisory Board, or perhaps no Medicare program at all. Because after all, the makeup of the voting public in 10 to 15 years' time is going to be different than what it is today. And the makeup of the voting population in 10 to 15 years' time may feel significantly different about paying 60, 65, 70, 75% of their paycheck in order to continue benefits that were promised by a Congress 60 years before. This type of intergenerational anxiety is just around the corner, and if we don't deal with it head on, if we don't take it as a serious responsibility, then it indeed could set the stage for some significant strife down the road between today's children and tomorrow's grandparents. And that is why it is so important that we address this situation today. GT, I have said what I had intended to say today. Let me yield back to you and for either additional comments or closing thoughts, and we'll wind down this hour a little early. Well, I appreciate that. Thanks again for hosting this hour. You know, what we can't do on this debate, whether we're talking about addressing the deficit or we're talking about saving Medicare, and frankly, both of those issues are intertwined. We've got to save the country, and we have to save the Medicare program. What we cannot do is allow the politics of 2012 to infect the problem solving of critical problems in 2011. And that's what we've seen so far. On the other side of the aisle, on something that is just been where the facts are evident and clear, where this country is facing a critical deficit that could bankrupt it, where the numbers for Medicare are such that its insolvency is impending and bankruptcy occurs and it goes away. These are critical problems, and they shouldn't be demagogued as we bring solutions to the floor to debate, and that's what has been happening. So there's no way we should allow the politics of 2012 infect the critical problem solving of 2011. Back after the Balanced Budget Act in 1997, I had the privilege of as a healthcare professional, being recruited to serve on a technical expert panel for Medicare. At the time, it was the Healthcare Finance Administration. Today, it's the Centers for Medicare and Medicaid Services.
based on that experience, this is necessary. This is a necessary debate. This is necessary to save Medicare, and it's an opportunity for us. We've had previous reforms. The most recent one I saw was under President Bush, where he created a waiver program. That was a reform to an entitlement program that actually increased quality of life and decreased costs. Many people who were institutionalized living in nursing homes, and frankly, I like nursing homes. I think they're quality. They can be very quality facilities. I was an administrator at one time. But people should have choice of where they live if they are living with a significant disability. It was President Bush's waiver program, a reform actually, that allowed that to occur. So reform is, I think, it can be a word that is used to scare people, but we need to talk about the specifics of why it's necessary and the opportunities that we can do to, I think, to increase quality of care, to decrease cost, to increase access even, all those, and certainly choice. And patients always, the healthcare consumers are making decisions. And those are four principles I think that we share as a caucus in whatever we do in healthcare. And looking at Medicare reform, I think that our plan, which is really the only plan, the only viable plan, it honors all four of those qualities. So I look forward to continuing this debate. We need to have a good, transparent debate, but it needs to be a debate that is not based on demagoguery. It's a debate that needs to be based on the facts. And so I'll yield back and thank my colleague for hosting this special orders time.
Well, I think we look forward to having similar discussions in the future, probably frequently, because it's important that we not just have the debate with both sides of the chamber, but it's important that we have the discussion, we have the conversation with the American people. And I would remind people that the Republican budget that was passed in April was an aspirational document. It wasn't terribly long. You look at something that becomes an actual law, and it can get fairly long and intricate. But the budget was an aspirational document that set the goals. In 10 years' time, we want to see Medicare on a sustainable path. We want to preserve, protect, and defend it for the future. And this aspirational document sets the pathway for achieving that goal. All of the work that will be done to actually develop the legislative product will be done in the committees that Mr. Thompson and I are on in the House and other members of the other body are on in the Senate. The actual work will be done in those committees, and there will be ample opportunity for people to comment, for people to contact their legislators, for people to there will be periods of open comment at the federal agencies as those laws are written, and they won't be written in the next couple of months. They will be written over the next several years. So I think the point I would end with is we are entering a phase of a long conversation with the American people about what the future of this program, which arguably has been a good program in the past but left untouched, is headed for some significant problems in the future. So what is the forward-looking path for our Medicare system and for our seniors of both today and tomorrow? And will be a long conversation, but we're both up to it, and we can talk for long times without pausing, and I look forward to working with you many afternoons on this very subject. And with that, Madam Speaker, I will yield back the balance of my time.
The gentleman yields back. Does the gentleman from Texas rise?
I move that the House do now adjourn.
The question is on the motion to adjourn. Those in favor say aye. Those opposed, no. The ayes have it. The motion is agreed to. Accordingly, the House stands adjourned until 10 a.m. on Tuesday next.
The House today debated a pair of resolutions on U.S. military operations in Libya. House Speaker Boehner's measure establishes that the President has not asked for congressional authorization